As we are running out of time, I thought of starting the lecture. So after two strenuous talks in the morning, now we are moving on to a sort of a clinical, interesting topic. I thought of talking about new trends. You know, the medicine is eternally changing. So as we are now in the medical field, if you like it or not, we have to get updated timely. So abnormal lipid values are very highly prevalent all over the world, and well-documented relationship between total and LDL cholesterol levels and the coronary heart disease risk is talked, and there is treatment to reduce the risk of coronary vascular disease or events. So early intervention is very important. Therefore, our laboratory tests plays a major role. So what is coronary vascular disease? It is caused by atherosclerosis, that is retention of lipids inside your vessels, right? And when the vessels supplying your heart get blocked by the lipids, you call it atherosclerosis, and you get ischemic heart disease. So let's see today's objectives. We'll briefly talk about the lipids and the lipoproteins, and then we'll go through the investigations available, and then we'll see what has changed during the past few years. So lipids. Lipids are everywhere in the cell, in your body, and also in the environment. So they are hydrophobic macromolecules. Hydrophobic means they don't like water. And macromolecules because they are very large molecules. As they are hydrophobic, they cannot be transported in the blood as their own. So they are transported bound to proteins and other water-soluble molecules. They play a vital role as a structural component, a source of energy, and source of biological active molecules. We'll talk about when we are moving. So what are lipoproteins? They are complex particles that have a central hydrophobic core of non-polar lipids. I told you by their own they can't travel through the bloodstream, so they have to be inside where there is a cover of hydrophilic molecules. These lipoproteins consist of esterified and non-esterified cholesterol, triglycerides, and phospholipids. And there is a apolipoprotein which is covering the whole molecule, and it gives it kind of a hydrophilic nature. So what are the types of lipoproteins? In our blood, there are various types of lipoproteins. I think it's clear to you. The larger one is the chylomicron, and then orange color ones you have chylomicron and chylomicron remnants, and then VLDL, IDL, excuse me, and excuse me, lipoprotein little a and LDL sort of kind of a similar size and density, and then you have high density lipoproteins which are very dense and small. So LDL is our major focus. What are the uses of lipoproteins? They mediate lipid transportation, and their metabolism plays a major role in day-to-day homeostasis. And it is a cofactor for enzymes and ligands for receptors. And let's see how these lipoproteins are categorized. It is mainly by ultracentrifugation. You can separate the lipoproteins by, you see the chylomicrons on top because it has very low density, and then the high density lipoproteins at the bottom because they are very dense and small. We can separate lipoproteins by electrophoresis also, but there is a subtle difference because now ultracentrifugation we take only the density, so it is separated according to the density of the lipoproteins. But in electrophoresis, as you all know, it takes both size and the charge. So there is a difference in the charge of LDL and IDL, so there is a subtle difference in separation in electrophoresis and ultracentrifugation patterns. So you can, if you observe the plasma overnight in a test tube, you can see all the lipids are separated. So the less dense lipids are floated up, and more dense ones go further bottom. So if you have a quite milky layer on top like this, it says the patient's serum is high in chylomicrons. I'm sure you all know chylomicrons are taken into the bloodstream from the intestine postprandially after meals. During fasting, you don't see chylomicrons in the serum. And if you see a fasting serum like this, it indicates that there is something wrong going on. If it is like this, but if the total cholesterol levels are high, you can infer that it is high LDL. And if there is homogeneous turbidity, it usually suggests high VLDL levels. We might need to know a little about the apolipoproteins, the proteins which covers the lipoproteins as we discussed in earlier. So ApoA1 is seen in chylomicrons and HDL. ApoB48 is in chylomicrons, and ApoB100 is in VLDL, IDL, LDL and lipoprotein little a. Those lipoproteins are dangerous lipoproteins. Each particle has one ApoB100 molecule. That is very important for us because the testing procedures are based on these facts. So remember, LDL cholesterol has ApoB100 molecules, whereas HDL molecules have ApoA apolipoproteins. I will briefly tell you the pathway for the cholesterol. As I told you earlier, we have our meals, and then they goes into the intestine where they are absorbed. And mostly they are triglycerides in chylomicrons, and they are taken to the blood. And from liver, LDL is produced, and LDL is taken into your bloodstream, where if they are in high concentration, they can get deposited in your blood vessels. And HDL, so-called good cholesterol, take cholesterol and other lipids from blood vessels or other peripheral organs to the liver to metabolize. So LDL is the bad one, HDL is the good one. And these chylomicrons are not present in our fasting samples. So let's move on to the laboratory investigations. We have serum total cholesterol levels, we have serum lipid profile, non-HDL cholesterol, Apolipoprotein levels are increasingly becoming popular, ApoA and ApoB, and then lipoprotein little a, again there is a new trend. And lipid electrophoresis and genetic testing, mostly for research purposes. And today we get all these tests together and say, extended lipid profile. Most of our laboratories offer this test these days. So we'll move on to total cholesterol. So we can get a sample for total cholesterol when the patient is fasting or even he is not fasting. We call it random cholesterol level. Non-fasting cholesterol levels, total cholesterol levels are acceptable for screening purposes. And if the cholesterol level is less than 200 milligrams per deciliter, which is desirable, and if it is more than 200 milligrams per deciliter, we have to proceed to a lipid profile. Anybody know why we have to proceed for a lipid profile? Why can't we treat the more than 200 level? Because in total cholesterol, we measure cholesterol of VLDL cholesterol, LDL cholesterol, HDL cholesterol, LDL cholesterol. I mean cholesterol in VLDL particles, LDL particles, HDL particles, and IDL and lipoprotein little a particles. So you can see each particle has cholesterol levels, triglyceride levels, and other lipids. So when you measure total cholesterol, now cholesterol is red color, we measure the total of this cholesterol as total cholesterol. So if it is more than 200, you cannot say whether it is dangerous or not, because he or she may be having a high level of HDL, so which may be contributing to that more than 200 total cholesterol. So you have to fractionate and see whether is this total cholesterol level is really bad or not. As ideal cholesterol and lipoprotein little a cholesterol are very minute in a usual blood sample, we usually ignore that. So totally we measure total cholesterol level of VLDL particles, LDL particles, and HDL particles. So for lipid profile, we take venous blood and it is collected to a plain tube without anticoagulant because we need the serum. So the lipid profile, we measure total cholesterol, HDL cholesterol and triglyceride levels. That I explained you the total cholesterol, we measure the whole total cholesterol content. And sometimes we measure LDL cholesterol levels and we calculate the LDL cholesterol level, VLDL cholesterol level and non-HDL cholesterol level, and also we can have the cardiac risk ratio. So I told you, now this time cholesterol is white in color, so we measure the whole amount of cholesterol. And when we measure HDL, we measure the cholesterol content of the HDL particle. And when we measure triglyceride, it is the triglyceride of all the particles we are measuring. And when we do direct LDL measurement, it is the cholesterol content of LDL particles we are measuring. So let's move on to the fasting lipid profile. It is usually, we learn it as 14 hours, but now they are reducing the fasting hours little by little. The time duration depends on the place you are working, that is the clinicians might tell you what is the preferable time duration for them. So to recall you that we want to remove all these chylomicrons from the bloodstream, that is why we are waiting fasting for certain hours. So the non-fasting lipid profiles, it is easy, convenient because we are not suffering from fasting. It is less cumbersome. Sample can be drawn at any time. It is more practical for us as laboratory personnel also, and it reduces the number of visits by the patient, and it is convenient process on economic and safety grounds, because sometimes elderly diabetic patients cannot stay fasting for long. So let's see what are the non-fasting investigations we can do. We can determine the LDL cholesterol levels through Friedwald formula. We'll discuss it further, but it is not that recommended. But there are newer equations we can use well with non-fasting state, and direct LDL we can do while non-fasting, but it is preferable to get a fasting blood level. Non-HDL cholesterol is when we take total cholesterol level and we subtract the HDL cholesterol levels. So it doesn't need fasting, because both total cholesterol levels and HDL cholesterol levels does not depend on fasting. So we can easily do the non-HDL cholesterol levels, and also the ApoB levels. I told you ApoB is the Apolipoprotein, which is in bad cholesterol. And if the non-fasting triglyceride levels are more than 400, so you have to proceed with the fasting lipid profile. So LDL cholesterol is the major risk factor, so it's a major target of the treatment as well. So we have to give an accurate measurement of it. What are the methods we can do LDL test? There are few methods. Beta-quantification is the gold standard, and there is direct LDL measurement, and we can estimate it by few equations. The most commonly used one is the Friedwald formula. Beta-quantification is expensive and it is very cumbersome, and it is not routinely done in our day-to-day practice. Direct LDL measurement, we use it when we encounter high triglyceride levels. But there are limitations because the LDL method is not standardized well. It correlates poor with, therefore it correlates poor with the gold standard, and it is not that accurate in mild hypertriglyceridemia and also in non-fasting samples. So this is the Friedwald formula we are using day to day. So we have total cholesterol, we have HDL level, we have triglyceride levels. So with that, how we can estimate the LDL cholesterol levels? We assume that the triglyceride level in the blood during fasting is only in VLDL. So in the VLDL particle, triglycerides to cholesterol ratio is 5. So we divide triglyceride by 5 to get the cholesterol level, and we can take the LDL levels. And this formula is not accurate when the triglycerides is more than 400 and the true LDL cholesterol level is less than 70. So is Friedwald doing good? It's not the best. So there are limitations of Friedwald formula because, as I told you, we assume that it's only VLDL which carries triglyceride, which may not the case. And we assume that LDL carries the majority of cholesterol, and it is also may not be true. And we use this formula to non-fasting samples, but you all know that chylomicronemia is there. So this ratio is not applicable in that situation. So it underestimate VLDL cholesterol and overestimate LDL cholesterol levels in non-fasting samples. And methodological errors may accumulate because we measure we get 3 readings and then we calculate. So errors in each method, each reading will accumulate, so the error will be more. So it loses accuracy. It loses accuracy when it is more than 150, and we cannot use it when it is more than 400 milligrams per deciliter. So there is a newer equation which is Martin-Hopkins. It is not really freely available as such. It is mainly useful when the LDL cholesterol is less than 70, where we cannot use Friedwald formula. Even in developed countries, it is not currently widespread yet because it is not validated fully for the whole population. And it is very difficult to incorporate into the LIS, Laboratory Information System, because they have a lot of equations we have to incorporate into the system. It is not a single equation. So there's another equation which is in practice very infrequent, but it is based on beta-quantification. It is supposed to be accurate than the Hopkins. It is a single equation and it can be applicable up to 9 millimoles per liter, which is an advantage compared with the Friedwald formula. But it is also need further validation. So we will see the good and bad cholesterol a little bit. This is the usual pattern of lipoproteins I showed you before. The yellow color is triglycerides and green color is protein part, and the gray color is free cholesterol. So lipoprotein little a lies somewhere here. So this is the demarcation. So HDL we all measure every day. It is a family of particles, so you have to take it as a whole rather than its mere cholesterol content. They are dynamic because in the blood they are continuously changing their constituents. You know, the high levels of HDL are potentially dangerous. As we thought before, however much HDL you get, they are protective, but it is not true anymore. High levels are dangerous. So there is a U-shaped association between HDL cholesterol and disease risk. So they have taken the cutoff. They are not very sure, but they think if he has more than 80 HDL, it is dangerous. So this is that graph. There is a U-shaped pattern with cardiovascular risk and the HDL. However, they are good as long as the reverse transport, which I told you from this one, when it carries HDL from blood vessels to liver, that pathway is, as long as it is intact, it is a good cholesterol. So this is the usual interpretative levels we use day by day. And this is our non-HDL cholesterol. As I told you, we take it by measuring total cholesterol, and then we subtract HDL cholesterol and take the non-HDL cholesterol, which contains all the atherogenic lipoprotein particles. So it is more represented the cardiovascular risk than LDL cholesterol alone. So as you see, non-HDL is HDL, the cholesterol particles other than HDL. It contains all the other particles. And it doesn't need fasting, as we discussed earlier. So we can use the cardiac risk ratio, that is total cholesterol to HDL, which is very familiar for you and me. And they use ApoB and ApoA1 instead of that. I'm sure by now you know why we are using the ApoB particles, because particle number represented the cardiovascular risk better than the concentration of cholesterol. So what are the pre-analytical concerns in lipid profile? So the patient ideally should have regular food habits during the 2 previous weeks, and he should not have strenuous exercise before the testing, and he should remain in sitting position for 15 minutes, and we should standardize the phlebotomy. And if the patient suffers from any disease, any fever, any other surgeries, so we should not take blood for lipid profiles until 2 to 4 weeks after. And if it is an acute ischemic event, we should take blood within 24 hours, otherwise we have to postpone it until 3 months. So these days we measure Apolipoproteins also levels. I'm sure by now you know what is the significance. We measure apoprotein A1 levels and apoprotein B levels. So we discussed that it is a better predictor of cardiovascular events because each atherosclerotic lipid particle contains one ApoB molecule. So it is more predictive of cardiovascular disease. ApoB measurements are standardized. There are methods now, standardized, automated, accurate, and inexpensive methods. I'm sure you all must be experienced, some of you. Fasting is not required, and Analytical performance are superior than the measurement of or the calculation of LDL cholesterol and non-HDL cholesterol. These ApoB levels are especially relevant in instances where the cholesterol level of the lipid particles does not correlate well with the particle number. For example, in diabetes, obesity, metabolic syndrome, and very low LDL cholesterol levels, this is very relevant. So as we are running out of time, we'll just rush through this. This is again a novel test, lipoprotein little a. It is very similar to LDL cholesterol particle, but it contains a little a, apo little a molecule with the particle, and it is an independent and causal risk factor for atherosclerotic cardiovascular disease. So they say at least once in lifetime you have to do the lipoprotein little a test. If the usual anti-cholesterol medication does not resolve your cholesterol problems. It is determined by genetics, and there are drug therapies available which can reduce lipoprotein little a levels, but it is usually conservative treatment. So it should, as I told you, we should consider lipoprotein little a in early onset. If the patient is very young, we should consider that. And in familial hypercholesterolemia, we should consider that. Poor response to statin therapy. And there are few other indications we should do lipoprotein little a testing, but not in all the patients. So there are immunoassays which can measure apolipoprotein A, which is rarely available even in the whole wide world. So there are variability of results across the different detection techniques. So there is lack of standardization and harmonization. So we have to work on that. So there are other special tests you can do, but they are mostly in the research type. So what is the best screening test if I ask you quickly? So still it's the standard lipid profile. We can do the non-fasting lipid profile also, but still we have shortcomings on that. And total cholesterol, single total cholesterol level is a better option for that. Sorry. So in summary, laboratory investigation is essential for diagnosis and management. It also introduces advance in science, thereby enhancing patient care. Investigations should not, however, strain limited resources as in our third world countries. All risk prediction tools have strengths and limitations and should be used in conjunction with clinical judgment. Thank you.